Aldosterone receptor blockers. Aldosterone receptor blockers, also known as mineralocorticoid receptor antagonists, are a class of potassium-sparing diuretics that act at the final stage of the renin-angiotensin-aldosterone system. Normally, aldosterone promotes sodium and water reabsorption while increasing potassium excretion in the distal nephron. By blocking mineralocorticoid receptors, these drugs oppose the actions of aldosterone, resulting in sodium and water loss while conserving potassium. The two clinically important agents are spironolactone and eplerenone. Where do they act? Aldosterone receptor blockers act primarily in the late distal tubule and collecting duct of the nephron, the final stage of sodium and potassium regulation. Let's now understand the mechanism of action of aldosterone receptor blockers step by step. First is receptor blockade. These drugs competitively block mineralocorticoid receptors in the distal nephron. As a result, aldosterone can no longer stimulate the synthesis of epithelial sodium channels and the sodium-potassium ATPase pump, both of which are essential for sodium reabsorption. This leads to decreased sodium reabsorption. Less sodium is taken back into the bloodstream, so sodium and water excretion increase, producing a mild diuretic effect. At the same time, these drugs produce potassium sparing by reducing potassium excretion. The overall result is a reduction in extracellular fluid volume and lower blood pressure while preserving potassium. The key concept to remember is that competitive inhibition of aldosterone receptors decreases sodium and water retention without causing potassium loss. Heart failure indications. Aldosterone receptor blockers have a particularly important role in heart failure, where their benefits extend far beyond simple diuresis. In congestive heart failure, these drugs are considered life-saving therapy because they prevent the harmful effects of chronic aldosterone exposure. Aldosterone promotes cardiac remodeling and myocardial fibrosis, which progressively worsen heart failure. By blocking these effects, mineralocorticoid receptor antagonists slow disease progression and improve long-term outcomes. They are especially indicated in patients of heart failure with reduced ejection fraction. Large clinical trials have shown that adding an aldosterone receptor blocker to standard therapy significantly reduces mortality, decreases hospitalizations, and improves survival. Hypertension uses. Their most common indication is resistant hypertension, where blood pressure remains uncontrolled despite treatment with 3 or more drugs. In such patients, mineralocorticoid receptor antagonists are added as add-on therapy and often produce a significant additional fall in blood pressure. They are also the drugs of choice in primary hyperaldosteronism or Conn syndrome, where excess aldosterone is produced by an aldosterone-secreting adrenal tumor. Another important indication is hypertension with heart failure, where these drugs not only lower blood pressure but also reduce morbidity and mortality by counteracting the harmful effects of aldosterone on the heart. Finally, in hypertension with hypokalemia, their potassium-sparing effect makes mineralocorticoid receptor antagonists particularly useful, especially when other diuretics have caused low potassium levels. Other therapeutic uses. Besides heart failure and hypertension, aldosterone receptor blockers have several other important therapeutic uses. The first is liver cirrhosis with ascites. In patients with liver failure, excess aldosterone contributes to abdominal fluid buildup, making spironolactone the drug of choice for managing ascites because it directly counteracts aldosterone-mediated sodium and water retention. They are also useful in nephrotic syndrome, where they help manage edema by promoting sodium and water excretion while conserving potassium. Another practical indication is diuretic-induced hypokalemia. When thiazide or loop diuretics cause low potassium levels, adding an aldosterone receptor blocker helps correct hypokalemia while maintaining the desired diuretic effect. The key point to remember is that these drugs are especially valuable in conditions associated with excess aldosterone, fluid overload, or potassium loss. The most dangerous side effect of aldosterone receptor blockers is hyperkalemia. Because these drugs are potassium-sparing diuretics, they reduce potassium excretion by the kidneys, which can cause elevated potassium levels in the blood. This becomes particularly dangerous in patients with kidney disease, where potassium excretion is already impaired. The risk also increases when these drugs are used together with ACE inhibitors or ARBs, since these medications also decrease aldosterone activity and further promote potassium retention. Endocrine adverse effects. Unlike hyperkalemia, these endocrine adverse effects are primarily associated with spironolactone due to its non-selective receptor binding. Besides blocking mineralocorticoid receptors, spironolactone also blocks androgen receptors and partially interacts with progesterone receptors. The most common endocrine adverse effect is gynecomastia, or breast tissue enlargement in males. Male patients may also develop impotence and decreased libido because of its anti-androgenic action. In female patients, spironolactone can cause menstrual irregularities by disrupting the normal hormonal balance. In contrast, eplerenone is much more selective for mineralocorticoid receptors, so these endocrine adverse effects are uncommon. Key takeaways. Let's conclude with the key takeaways from aldosterone receptor blockers. First, remember that they are potassium-sparing diuretics. They block mineralocorticoid receptors in the distal nephron, reducing sodium retention and water reabsorption while preserving potassium. Second, they have broad therapeutic value. They are indicated in congestive heart failure, resistant hypertension, Conn syndrome, liver cirrhosis with ascites, and nephrotic syndrome, making them useful in a wide range of cardiovascular and renal disorders. Finally, always watch for hyperkalemia, the most dangerous side effect, especially in patients with kidney disease or those receiving ACE inhibitors or ARBs. If the endocrine effects of spironolactone become a concern, eplerenone is usually the preferred alternative because of its greater receptor selectivity.